Good evening, everyone. Welcome to our live webcast, Minimally Invasive Spine Interventions, Vertebral Augmentation, and Decompressions, including the endoscopic approaches. Thank you again for joining us tonight. This webcast is sponsored and hosted by Azra Pain Medicine and by the Association of Pain Program Directors for you, the junior colleagues, future colleagues, and our fellows. My name is Rene Przkora. I practice at the University of Florida. I'm the program director there, and I'll be serving as the moderator for this webinar. I'm also very honored to be joined by our speakers, Dr. Joshua Pan and Dr. Dalia Elmofty, both practicing at the University of Chicago, Pain Medicine. And we're also joined by Dr. Wahezi, practicing at the Montefiore Medical Center in New York, and also by my colleagues from the University of Florida, Dr. Matthew Meroney, Amir Jafari, and our fellow Rohan Sarna. Again, thank you very much for joining us. Before we move along to the single presentations, I would encourage you to use the Q&A feature at the top of the screen. Again, the Q&A feature at the bottom of your screen. My apologies. To place any questions you might have to the presentations and the speakers, and we will answer them in an order at the end of all presentations. So even if you have a specific questions, place it in, and we will get to it. But we will have all presenters speak first. Again, thank you very much for joining us today, and it's my pleasure to start this webcast with Dr. Joshua Pan from the University of Chicago, and he will talk about vertebral augmentation.
All right. Hi, everyone. I'm Dr. Joshua Pan. I'm one of the interventional pain providers at University of Chicago. Let me get this in presenter mode. Okay, I have no faculty disclosures, and everything on here will be on-label use. So learning objectives for this, specific indication for vertebral augmentation, procedures in clinical practice, describe available techniques and technologies, and then understand complication, adverse events that can arise from performing these procedures. So vertebral compression fractures can be pathologic, either from malignant causes or osteoporotic, can be caused by trauma. Diagnosis is done with X-ray or MRI as the gold standard. MRI will demonstrate the acuity of the compression fracture, showing acute or subacute edema on the MRI. When treating compression fractures, I do think there's a lot of value to getting MRI imaging for compression fractures. This is a study looking at the value of MRI before doing a kyphoplasty procedure, and about 40% didn't change the procedure at all, but it did potentially either increase levels, reduce the levels, change the level, but the same number of levels, abort the procedure as well. So in over half of the patients in this study, it did change the procedure planning for these patients. I've made the mistake of getting lumbar X-rays, and then the top of your lumbar X-ray shows a T12 or T11 compression fracture. So when you see those, go ahead and order additional imaging if you're looking at thoracic spine as well. So compression fractures in cancer patients, estimates about 75 to 100,000 cancer-induced vertebral compression fractures annually, with lung and breast cancer making up a large portion, in addition to multiple myeloma and then prostate cancer. As you can see, the different breakdowns, with prostate cancer being as a single cause, one of the largest, then followed by multiple myeloma. Multiple myeloma, over 70% of these patients have bone pain at diagnosis, and half have back pain. Over half of them have a history of vertebral abnormalities, and then about 15 to 30% will develop new vertebral compression fractures annually. About half of these patients have at least one osteolytic lesion, which develops into a pathologic fracture within 9 months. So why do these happen? Vertebral compression fractures in cancer patients. So one is from the cancer itself. So metastatic bone cancers with lytic lesions can spread in the setting of breast cancer, prostate cancer, multiple myeloma, like I was saying. Other causes, chemotherapy, and chronic steroids, so they can cause secondary osteoporosis, which increases the risk for vertebral compression fractures, and then radiation. There's kind of conflicting evidence on it, but radiation associated compression fractures as well. Radiation doesn't prevent fractures in treatment and does not correct any anatomic abnormalities from fractures. Osteoporotic compression fractures, which is the other side of things, about 1.5 million cases worldwide. Conservative therapy does work in a lot of these patients and can heal in 3 months, but in some of your older patients, it can't. I've seen subacute edema out to 9 months to almost a year. Selection process identifies ideal candidates for long-term positive outcomes and looking at vertebroplasties versus kyphoplasties in these specific patients, which I'll get into a little bit more. So how do patients present with compression fractures on the clinical side? So there's usually an acute event, a sudden onset of back pain, specific point tenderness that's reproducible, girdle belt-like pain, muscle spasms. Patients that have had these compression fractures for a while may demonstrate loss of height, spinal deformities such as kyphosis, and then protuberant abdomens from the shifting of the vertebral bodies. Subsequently, over time, this can change the patient's gait through changing the way that they bend at the knee, increasing pelvic tilt. This changing gait affects the balance and puts these patients at increased risk for additional falls and potential fractures, especially in your osteoporotic patients. They'll be highly susceptible to additional fractures, whether it's additional vertebral fractures or other bone fractures after falling. So future fracture risk, patients who have vertebral compression fractures are at risk for future fractures. It's 5-fold after the first compression fracture, 12-fold if you have 2 or more. And then if you have 2 or more and low bone mass on your DEXA scans, it puts you all the way at 75-fold for increased compression fractures. So it's not unusual to see one of these patients, provide a kyphoplasty, and then a few months to a few years later, they present back with a future compression fracture. So before you do a kyphoplasty, you need to understand the contraindications. So systemic infections is a very obvious one. Healed fractures, old fractures, or non-painful lesions. Patients that have discitis or osteomyelitis at the level that you plan to intervene on. Coagulopathies, typically INR greater 1.2 or platelets less than 100,000. Loss of the posterior body wall integrity, because you'd be concerned about cement pushing back into the spinal canal. Retropulsion, especially if there's stenosis at that level. And then pars plana is basically when the vertebral body is too collapsed to actually intervene on, and is almost thin and pancake-like. And then tumor that are invading into the epidural space. So vertebral augmentation techniques. So for bone metastasis and osteoporosis, you can do percutaneous cementing of the collapsed vertebral body only when symptomatic. You can do a transpedicular approach where you contact bone at all time, which is generally thought to be somewhat safer. And then you can also do extrapedicular at a more acute angle with no bone contact, but thought to be somewhat less safe. There are small studies demonstrating that there's probably not a huge difference in safety, but I think traditionally most people have trained in a transpedicular approach, and having the feedback of being on bone and or within bone is helpful, and also shifting of the cannulas when you're inside the pedicle rather than outside the pedicle may provide a little bit more safety margins. On the flip side, when you are transpedicular, if you're too medial, you can be too close to the spinal canal, and that's where you can run into injuries of the spinal cord from that standpoint. So there's both risk and benefits to each approach, but I think most people generally do a transpedicular approach. So how to do the actual procedure? So you need to get your C-arm lined up in a good AP view and a good lateral view. Making sure that you can clearly see the pedicles. So in image at the top left, you can see image A, where you can see the pedicle. So on the pedicle, if you think of it as a clock face, the 6 o'clock is kind of your safety margin. So once you pass the 6 o'clock, if you are not through into the vertebral body, you could potentially damage the interrupt the spinal canal. So before you cross that 6 o'clock line, you need to check your lateral to make sure that you've advanced into the vertebral body. Let me see this let me show right here. So you need to be able to cross right here on the vertebral body through the whole pedicle before you cross this 6 o'clock mark right here on the pedicle. Here's kind of demonstrating the extrapedicular approach where you're outside the pedicle going into the vertebral body. But most people, like I say, tend to prefer the transpedicular. So this canyon will be a little bit more medial, traveling through the whole pedicle into the vertebral body. This can be done with uniplanar or biplanar imaging. This is kind of demonstrating how the C-arms are positioned for biplanar imaging. The advantages to doing a biplanar is you don't have to readjust the C-arm in between your AP and lateral shots, but the disadvantage is you have to be able to fit 2 C-arms in your procedure suite. If you're in a outpatient pain clinic office, you're probably not going to have two pain office C-arms available. But at some of the academic centers, it's pretty easy to get 2 C-arms available for that. Typically, if you're doing 1 level, it's probably not necessarily to do two C-arms, but if you're doing multiple levels, it can definitely cut down on some of the procedural time. If you have to go through multiple levels for vertebral augmentation. So I talked about transpedicular versus transpedicular versus extrapedicular. Then there's unipedicular versus bipedicular, just meaning do you go through one of the pedicles or do you go through both of the pedicles? Historically, when these were first being done, it's all being done mostly by bipedicular approach in order to get good cement spread. As equipment has improved and cannula technology has been able to get more directed spread of the cement, unipedicular approach has been more favorable for most people. The advantages to unipediculars are shorter surgical time, less blood loss, and less cement leakage. And cement spread is usually almost as equal as it is with bipedicular. So for vertebral augmentation techniques, so the basic one, or the standard ones that we think of are kyphoplasties, which involve a balloon to reduce the fracture and creates a cavity, versus vertebroplasty, no balloon, but you inject cement into the compression fracture and vertebral body. So here's demonstrating some of the height gain from vertebral augmentation. Some of the newer methods include the PEEK implant that you can see on the images on the left, and other newer devices are the spine jack, which you can see on the bottom right. These require a bipedicular approach, though, so these can't be done through one pedicle. So they do take a little bit more procedural time. For cancer patients, you can do thermal bone ablation. This can be done with traditional RFA or with water-cooled. The advantages to the water cool is the disadvantages to the conventional is you can have possible charring, can take a little bit longer, versus the advantages is there's no charring and you can get away with potentially 1 lesion. Ablative techniques, like I said, conventional versus water cooled. This is kind of similar to your traditional RFA versus water cooled RFAs that you do maybe for facet arthropathy for medial branch ablations. Let's see. So this is a table just kind of summarizing the differences: kyphoplasty, vertebroplasty, PEEK implant, and spine jack. With the vertebroplasty not creating a cavity, but all the other procedures create a cavity before either injecting the cement or placing the device and then injecting the cement. So the benefit of vertebroplasties and kyphoplasties has been looked at in a lot of retrospective studies. These are kind of a summary of some of the bigger studies looking at vertebral augmentation. Most of them demonstrating significant benefits in improved mortality and morbidity in patients that undergo vertebral augmentation compared to those who don't. So in pain medicine, a lot of what we do is palliative, and it's to help patients with their pain, but this is actually something that could potentially reduce their long-term risk from that standpoint. So these are studies looking from 10-year follow-ups to some of the shorter ones at 3-year follow-ups, ranging from 10 to 15% reduced mortality to all the way up to 55% reduced mortality at one year to 3, 5, and 10-year marks. To finish up, just so everyone else has enough time to chat, some of the complications that can be seen: you can get cement spread where you don't want it, so into the spinal canal, into neuroforamen. These can have either transient or permanent injuries. If you're getting into the spinal canal, that's definitely an emergent situation that you need emergent surgical decompression. If you're getting into other areas like the intervertebral disc, usually you can get away with conservative management, but on occasion you'll need surgical intervention. Other things, anytime you enter a bone, you can get fat emboli. Anytime you're injecting cement, you can get cement emboli, epidural hematomas if you go into the spinal canal. And then with all pain intervention procedures, there's always risk of infection, allergic reactions, and then in your thoracic spine, you can get rib fractures as well. So in conclusion, vertebral augmentation techniques are utilized in pathologic or osteoporotic procedures for patients. Indications and timing of the procedure is essential for optimal outcomes. In metastatic vertebral compression fracture, several devices do sterilize the tumor by radiofrequency ablation. Then complications do exist in vertebral augmentation procedures and are primarily present in patients who are debilitated with various other comorbidities. And that is my presentation. Thank you so much.
Thank you very much for your outstanding presentation. And to start this webcast, I think the next speaker is Dr. Syed Wahezi. And he will be talking about the minimally invasive lumbar decompressions, the so-called mild or MILD procedure.
As Rene had mentioned, my topic is to discuss the mild procedure. Now, there's a lot to talk about here. I will keep it close to the 10 or 15 minutes that I have, ensuring that everybody else has enough time to speak as well and to share their insights, which likely built upon this particular procedure. So mild is indeed minimally invasive lumbar decompression. Moments from now, I'll tell you why I don't really love that name. And why I think that the name actually should have been something different. And had it been something different, it may not have had as much of a tumultuous history as it does. And we'll talk about that a little bit. I do not think that you can speak about this procedure or give an introductory lecture with it without talking about the issues that the political issues that it brought with it when it first came about around 2008 or 2009. All right, so here are my disclosures. I am part of the Vertos Clinical Leadership Council. I was an investigator for the Encore trial, which we'll discuss momentarily. I was an investigator for the Motion trial as well. Okay. These were both RCTs that were done for mild. This was mild versus ESI and mild versus conservative medical management. Okay, why is this procedure done? This procedure is done primarily for patients who have neurogenic claudication. And in the best of case scenarios, it's done for patients who have neurogenic claudication with primary ligamentum flavum hypertrophy. Ideally at 1 or 2 levels, but more than 2 levels have been performed, okay? I'll show you pictures of what ligamentum flavum is. I'm sure that most of you know, but I will hopefully culture you on modestly more complexities of axial projections on MRI. There's a lot of people who have lumbar spinal stenosis. We're dealing with an elderly population. Most of this elderly population has a degenerative spine pathology. Those the degenerative spines could be either because the discs are dehydrating, and that's causing a disc collapse, subsequently causing facet hypertrophy. After the facet hypertrophy, then you have buckling rather of the ligamentum flavum. When one has buckling of the ligamentum flavum, that's how the ligamentum flavum then invades into the central canal. There's other patients who will have central canal stenosis as a consequence, primarily due to facet hypertrophy. When facet's hypertrophy, one will then get a lateral stenosis. So the encroachment upon the thecal sac becomes more lateral. And in those cases, it's a little bit more challenging to treat these patients. Okay. Basically, the information that I have on here in short says There's a lot of people who have lumbar spinal stenosis with neurogenic claudication, and surgeries are done for this particular population. Surgeries cost a lot of money. Mild costs a lot less. And so that was the reason for the creation of this particular procedure. The device was created by a neurosurgeon, and it was not readily accepted by the neurosurgical community, primarily because the procedure is done under fluoroscopy. And because it's done under fluoroscopy, and in the initial iterations of the technical aspects of this procedure, because an epidural was absolutely needed in order to determine safety, many neurosurgeons and many orthopedic spine surgeons would not utilize this procedure in their armamentarium. So then there was a flex within the within industry to then move the handles of this procedure over to the pain community. And once the pain community embraced this, well, then a story developed. There were political complications with the procedure, okay? As I mentioned earlier, the procedure came to form around 2008, 2009. That's when pain practitioners were starting to use this device. As I mentioned earlier, an epidural is needed for this, and I'll show you pictures of that later on. Once the epidural is performed, primarily two devices are used to rongeur some of the bone between the interlaminar spaces, and also a tissue sculpture is used to remove some of the ligamentum flavum. Now, as I mentioned before, MILD is an acronym for minimally invasive lumbar decompression. That word decompression was something that for many, many decades was, and I think still is, the IP for neurosurgeons and orthopedic spine surgeons. So once they realized that pain physicians were using a minimally invasive decompression device for treatment, they became upset. And upset is a term I'm using lightly. The terms minimally invasive were also something that was cultured within the surgical spine community. So when you bring those words together, and when a specialty brings those terms together, but then realizes that another specialty is using that nomenclature IP, then feathers are rustled. I will tell you that when I started doing this procedure, I was made modestly uncomfortable by some colleagues who I worked with. But as you'll see here, it was through determination of science, through determination of patient registries, as well as RCTs, that we were able, and I was able to kind of come out of the woods and advance as someone who did these procedures and subsequently was highlighted because of them. I encourage everybody who's listening to this webcast tonight to make sure that you understand that with almost all of the things that you see today, there will come with it some degree of political strain. Make sure that you create a good communication with your surgical community. Make them understand that the patients that you are doing these procedures for are patients who are not surgical candidates. Now, these patients could be not surgical candidates because the patients don't want the procedure, right? That's an exclusion criteria, or because the surgeons have excluded them, right, for one reason or another, but yet they're safe enough to have these percutaneous procedures done, all right? So that having been said, I want everybody to understand that after neurosurgery and orthopedic spine surgery kind of became overseers of how this particular device was utilized, Medicare then created a mechanism of payment for this procedure. And that was a coverage under evidence determination, which was one of the first pain procedures that I think it actually may be the only pain procedure that had this coverage term. Medicare came to us as the investigator community and said, look, we want you to build a study that we're going to oversee, we being Medicare, that we're going to oversee. And we want you to show us that this procedure is better than epidural steroid injections. Now, there have been several studies that were done before this particular CED. So we created a procedure, Medicare approved it, and once Medicare approved it, Medicare partially subsidized the procedure. When they subsidized the procedure, we demonstrated both 1 and 2 year data. They only wanted 1, we gave them 2. They wanted 150 patients, we gave them 300. At the end of this CED research study, which was the Encore study, the Medicare Encore study, we demonstrated that greater than 2 to 1, patients who had the mild procedure did better than ESI, not only in terms of pain improvement, but in terms of patient function. ODI improved by double compared to ESI, and it had 2-year durability, where the ESI is demonstrated anywhere between 3 to 6 month durability. So in every single measure and exceeding Medicare's outcomes, we determined and demonstrated that this was better than ESI. We thought at that point in time that mild was going to be given a CPT code, which means that they would then have mild would then have the ability to be used almost universally, not only by Medicare, but also by private insurances. And what ended up happening was Medicare turned around and said, thank you, Wahezi et al. For all of your good research. But what we're going to do is we're going to sit on this. We're going to table the discussion. We will see how this research then progresses throughout the community. So we will do our own post-research evaluation and then determine later on if we're going to cover this. And now we're still sitting at a point where mild does not have a level 1 code yet for reimbursement. Now, Medicare still pays for this, and Medicare pays pretty well for this, but private insurances have become modestly challenging. There are extender codes that one has to use in order to get this paid for, and the payment can be done, but it's not as simple as most other procedures that you'll be hearing about tonight. So I just want people to be aware of that. Okay, this is the picture that I wanted to show you earlier. Obviously central canal, obviously thecal sac, lamina, here's ligamentum flavum. This is what happens when it thickens or buckles. This is what this device is removing. When facets get really large out here, not here, and one gets encroachment, the device cannot and should not be used for lateral recess stenosis. Okay, nerve roots do sit fairly closely out here, and when one is debulking, and when one is not an expert at debulking in these lateral recesses, one can take out nerve roots. Now, when one looks at the MAUD report, which is basically an online service that outlines the negative outcomes related to a device, one will see that this is actually a very safe procedure. And when done in the right hands, and when evaluating things the way that I've just outlined for everybody here, it is a very safe procedure with a complication rate of less than 1%. And that's actually what we found in our Encore and motion studies as well. Okay. This is demonstrating neuroforaminal stenosis. Now, the device is not designed for neuroforaminal stenosis, but as a secondary outcome in our motion study, what we did demonstrate as a subcohort analysis was that patients who have neuroforaminal stenosis also do better than ESI with greater durability as compared to ESI. Okay. There's a lot of these procedures that have been done to date, and I think I gave you the history with regards to the CED and the number of patients that this has treated within the CED as well. How do you do it? Well, back when I first started doing this, an epidural steroid injection was mandatory. I still teach my fellows the same, and when I do teach courses, I do suggest that an epidural is done, just because it gives a very good visual as to how close one is actually getting to the fecal sac, because I want to make sure that people understand and appreciate that when one puts in the devices within the canal, that you can actually abut, and one does abut the fecal sac. So when one is not using an epidurogram in this procedure, I want them to think about what they saw during the epidurogram and know that they are getting very close to this fecal sac. All right. And so when they are removing tissue, you know that you are, you're in an area where you have to have very excellent manual dexterity and also excellent fluoroscopic visibility and technical acuity. Okay. So the procedure is primarily done on a contralateral oblique view. Epidural is done in standard view, preferentially within the central canal that's already tight. Now, some physicians may have central canals that they're working on that are so tight that even an epidurogram causes pain in a patient when they're given light sedation. So for these patients, fentanyl and Versed is primarily what I provide. Other patients have been given propofol in other institutions. I've done this procedure in patients with just local anesthetic when they haven't wanted to be put to sleep. And I've had success with every one of those scenarios, okay? But just be mindful that if a canal is really, really tight and you do an epidurogram and the volume that you have to drop in here is anywhere between 3 to 10 cc's, that you could actually create an iatrogenic pain and sometimes an iatrogenic neural compromise. So once that is done, and if you're able to do it at that level, great. If not, my suggestion is put it in an area distal to the central area of stenosis. So if this is at 4.5, drop it in at 5.1 and just watch the contrast flow up. You'll need greater volumes, meaning up to 5 to 10 cc's to see that. Then you get your contralateral oblique. There is a bone rongeur and a protective tool that's used as a stopper to make sure that your devices do not enter deep into the central canal. And then on this contralateral oblique, basically you put in the bone rongeur. You can take down bone to create room for your tissue sculptor, or as I like to do it, just use the bone rongeur for everything. The ligamentum flavum, I'll go to this picture here because it's just cleaner from my point of view. Once the tissue sculptor goes, or rather once the bone rongeur goes in here, you can actually take bites out of the anterior elements of this lamina. The lamina is adhered to the ligamentum flavum by Sharpey's fibers, and when these Sharpey's fibers are removed, you're naturally decompressing and taking away ligamentum flavum. Once you take it away, I have a small sterile cup with sterile normal saline in it. And then I just take a piece of telfa. I remove the telfa from the tissue rongeur, or for the bone from the bone rongeur or tissue sculptor, and then basically I have tissue on hand. Okay, I make a pass through until I can demonstrate that the contrast is flowing more freely. There is not a standard way of knowing when you're done. I typically figure out when I'm done when I can't pull any more tissue out. All right. You can pull out anywhere between 1 to 3 grams because people have weighted. I've not weighed it, and that's not standard, but just bear in mind that that's the case. My team and I did create MIST guidelines for not only this procedure, but also for other minimally invasive decompression treatments that exist. And basically within the MIST guidelines, what we demonstrated and what we speak about is that if a patient, for the mild procedure, if a patient has dynamic instability, do not consider doing this procedure, all right? Especially if they have a dynamic instability that is also causing primarily back pain, because those patients are surgical candidates, meaning they're going to likely need a fusion. Now, if a patient has significant central canal stenosis and they cannot have a fusion, then you can consider doing something like medial branches, radio frequency ablation for this set component, but then also doing a lumbar decompression to open up some of the spinal canal. All right. If a patient has neuroforaminal stenosis, what we suggest is do indirect decompression, which is a spacer related treatment. I want to be pointed to the fact that When it comes to dynamic instability, we're actually writing a paper right now outlining what the visual markers are for dynamic instability. And in the past, what people would use as a flexion extension X-ray to understand and demonstrate this. And now we're realizing that that's not the best way to understand dynamic instability. And instead, using a patient supine versus a patient who is who's standing and or flexed is the best way to understand if there is true dynamic instability. Those would be the two radiographic positional elements that I would suggest, and more surgeons are abiding by that as well. Okay. And just understand that the MIST-2 guidelines, we've published this as well. We basically elaborated on the MIST-1 guidelines, but then ended up adding interspinous spacer fusion products as well. The MIST-3 guidelines we're working on right now, and in that particular document, we're talking more about fine-tuning things such as the listhesis, dynamic listhesis things that we just talked about, and there'll be more in there as well. That will probably be published within the next 6 to 12 months. And that's it for me. Thanks, everybody.
Thank you very much for your presentation, and I'm delighted to move to the next speaker. This is my colleague Dalia Elmofty from the University of Chicago, and she will talk about interspinous process devices. Dalia?
Good evening, everybody, and thank you for joining us today. So these are my disclosures. I do receive travel expenses from Azure and NANS, and I will not be talking about any off-label devices. My objectives today are to kind of go over again and define what lumbar spinal stenosis. I believe repetition leads to mastery. So I know you heard Dr. Wahezi kind of describing spinal stenosis. I'll reiterate it. And then I'll be talking about different types of interspinous process devices. As you all know, lumbar spinal stenosis, obviously it's a disabling condition, usually affecting our baby boomers, those 60 and above. It is estimated that it affects about 103 million persons worldwide. In the United States, about 11% of the adult population suffers from it. And it's approximated that about over 600,000 surgical procedures are performed within the United States annually to treat lumbar spinal stenosis. So what's the pathophysiology behind it? And I know we discussed this a little bit earlier, but really it leads to canal narrowing, right? Where there's compressions of nerves and blood vessels. And the narrowing can occur either centrally in the lateral recess or within the neuroforamen, leading to certain symptomatologies such as pain, numbness, or weakness in the low back, as well as the buttocks radiating to the legs. That's typically worsened by prolonged walking or standing and relieved by sitting or flexing forward. I don't know if you guys can see my cursor here on the slide, but on the right side, figure A basically shows a healthy neuraxium, right? Where we can see in the middle, the caudal point of the roots are freely floating within the CSF. There's no compression in the lateral recess, and the nerves are pretty free in the neuroforamen. In image B here, you're seeing a posterior disc protrusion causing central canal stenosis and narrowing of those rootlets within the canal. You're also seeing some lateral recess narrowing as well as pyramidal narrowing. This is on axial image. On sagittal images in patients who have spondylolisthesis, and basically that is a shift of one vertebral body over the other. What that usually leads to is some form of facet hypertrophy, and that can lead to neuroforaminal narrowing. When there isn't any spondylolisthesis, it's usually canal stenosis occurring either from a protruding disc or from a thickened ligamentum flavum. How do we clinically diagnose this? Obviously, by taking thorough medical history. Patients will typically give you symptomatology of what we call the shopping cart sign, again, where standing and extending worsens the pain, but sitting, flexing forward improves the pain. Physical examination is important, imaging, CT or MRI. And if the clinical presentation isn't as clear as you would like it to be, sometimes EMGs can be helpful. When we talk about imaging, we do use a certain grading system to stratify spinal stenosis. There is the Lee grading system, which uses a 4-point grading system that basically looks at the degree of obliteration of CSF. in front of the cauda equina within the dural sac on two weighted images, while the Shikazis, I can never pronounce that, uses a 7-point grading classification that looks more at the morphology of the dural sac and the ratio between the rootlets and CSF on T2 weighted imaging. Treatment options, I'm sure you guys are all familiar with this, but there's non-pharmacological, pharmacological, interventional, and surgical. The non-pharmacological patient education is really important, right? And helping the patients understand the disease pathology and the relationship between posture and symptomatology, encouraging exercises that are more flexion-based, such as biking or swimming and side strokes, as well as physiotherapy, aquatic therapy, and other non-pharmacological methods. Pharmacological, our NSAIDs or acetaminophen, membrane stabilizers, antidepressants can be utilized. Interventional epidural steroid injections, as Dr. Wahezi mentioned, the minimal invasive lumbar decompression, and what I'll be talking about shortly, interspinous process devices. Of course, surgical procedures are options. There's decompressive surgery, basically meaning laminectomies to help compress the canal, but as well as decompressive surgery with lumbar fusion if there is instability. So, kind of getting to the content of my discussion today, interspinous process devices. When we talk about these, there's really two types of interspinous process devices. There's interspinous distraction devices and interspinous stabilizers. What's an interspinous distraction device? Well, basically a device that's going to separate the adjacent spinal processes to provide indirect decompression of neurological structures during spinal extension, but they do not stabilize, and they may loosen over time, basically increasing the risk for migration. With interspinous stabilizers, they have the same properties as the interspinous distraction devices, but they can fixate adjacent spinal processes by bracing components and can provide a larger degree of stability to adjacent levels. And oftentimes these are used in combination with surgical decompressive procedures. So the different types of interspinous distraction devices, the one that most pain or interventional pain physicians are familiar with, which is the Superion or Vertiflex. There's other devices such as X-Stop, InSpace, and Spurious that I'll briefly discuss. Some of the interspinous stabilizers include the Coflex, the Diam, which stands for Device for Intravertebral Assisted Motion, and the Wallace. So what do these interspinous distraction devices provide? As I mentioned earlier, they will achieve indirect decompression without jeopardizing stability at the instrumented level. They will somewhat limit extension, but will still preserve some degree of flexion at the level that we're treating. They will also result in a stretch of the ligamentum flavum and therefore reducing its thickness, and result that can increase the diameter of the spinal canal, again, allowing for flexion to relieve some of the symptomatology from compressed nerve roots. With these devices, usually motion is preserved at that level, and sometimes it can alleviate the stress that occurs at the adjacent level that sometimes we again see with surgical decompressive procedures. With the interspinous stabilizers, they as well decompress the neural structures, and like I mentioned earlier, they are oftentimes used with open surgical decompressive procedures. They do achieve stabilization, and sometimes they are actually utilized to help improve posterior element stabilization. When surgeons find that there's a lot of instability interop, sometimes they'll place these devices to help with that stabilization. What are some of the indications of the interspinous process devices? Again, lumbar spinal stenosis, right? Whether it be from degenerative discs or whether it be from herniated discs. Usually it's indicated in patients who've failed what we consider conservative management, as I mentioned earlier, the non-pharmacological, pharmacological, and sometimes interventional procedures such as epidural steroid injection. They can be utilized for patients who have scoliosis, and certain devices, the Cobb angle is variable. Some devices will say a Cobb angle of less than 10 degrees, while others will say a Cobb angle less than 25 degrees. They can also sometimes be utilized for interspinous pain that occurs from what is known as Bastrup's or kissing spine disease. And again, some devices it's contraindicated in its utilization, while other devices it can be utilized. And again, anything that is less than grade 1 spondylolisthesis, or grade 1 or less. What are some of the contraindications? A lot of it is somewhat common sense, right? If you have cauda-equina syndrome, that's a neurosurgical or emergency, and surgical decompression is usually required. If you have any element of osseous deformation, right? If you have a spinal fracture, if you have a pars interarticularis fracture or a laminar fracture, this device actually lands on these structures. So any instability or fractures in them obviously can result in malfunction of the device. Some of the other relative contraindications, obesity is BMI of greater than 40. If you have osteoporosis or bone immaturity, and again, if anything greater than grade 1 spondylolisthesis, it's considered a relative contraindication. If you have severe canal stenosis, it's usually not recommended to utilize these devices. And some literature suggests if you have more than one level of moderate canal stenosis, it might not be recommended. So I'm not really going to go over the exact technical aspects about performing these procedures because we just don't have enough time. But I will highlight on some of the differences between devices. And as full disclosure, I do not perform any of these procedures other than Superion Vertiflex. I do not utilize any of the other devices. So for the Vertiflex, as we mentioned again, indication is for moderate canal stenosis, and that's usually defined as a 25 to 50% reduction in the central canal or nerve root compared to the adjacent level on imaging. It is also indicated in patients who have a Zurich score of greater than or equal to 2. And usually these patients should at least be able to walk 50 feet or sit for about 50 minutes. If they can't, that's sometimes indicative of more severe canal stenosis where surgical decompression is recommended. We kind of briefly already touched based on the mechanism of action. It is an interspinous distraction device, not a stabilizer. It will allow flexion, therefore decompressing the canal, and it will limit extension, which compresses the canal. Patient selection, again, we talked about it a little bit earlier, those that present with neurogenic claudication. It's also recommended, of course, making sure that your patient doesn't have osteopenia and getting a DEXA scan and making sure hip and spine has no more than 2.5 standard deviation below the normal mean value for adults. It is still recommended that flexion extension films are obtained, and there shouldn't be any more than 3 millimeter translation on axial view or greater than grade 1 spondylolisthesis. The advantages, as you'll see with many of these devices, they are reversible. There's no resection of an anatomical structure. They're minimal invasive, and there is data that shows efficacy. Again, I'm not really going to go through the all the data, but it is available to you on these slides to take a look at. Another device, and again, disclosure, I do not place this device, the Minuteman G3. This is kind of more of, I guess I would say, interspinous stabilizing device. It basically can provide fixation for thoracic, lumbar, sacral spine. And this device basically has these bilateral locking plates that attach on both sides, and a bone graft is placed in the device. So again, leads to somewhat, you know, a limitation in range of motion, if you want to describe it as that. They are placed via lateral incision, not like the Superion, which is placed through a posterior incision. Patient selection is pretty similar to the Superion. Again, advantages is it's minimally invasive, and again, can provide stabilization of the spine. The Coflex, another type of interspinous stabilizer device, and also usually utilized in combination with open surgical decompression. Patient selection, again, patients who have moderate, but can also be used in patients who have severe lumbar canal stenosis, again, because it is used with open surgical decompression. It basically, as you can see on the image here, it's kind of like this U-shaped titanium implant. The implant loads within the interlaminar bone and kind of compresses with extension, and therefore that U shape that allows the bending. It also has these bony ridges that hinge onto the spinal process that prevent its migration. Again, advantages, minimally invasive if done by itself, but again, usually commonly done with decompressive procedures. The X-stop, another type of distraction device. This was actually considered one of the first generation devices, titanium alloy. And this basically consists of a spacer with a wing assembly. There's literature that supports, improvement in clinical outcomes. A more recent meta-analysis in 2023 reported when comparing it to laminectomy, there were improved outcomes or long-term outcomes and cost effectiveness with laminectomy versus the X-stop. Some of the other devices, again, we're running out of time, so just kind of to quickly, the Asperius, the Diam, the Wallace, the InSpace, again, some literature that shows some improvement in. When we take a look at these devices and we want to compare it to conservative therapy versus open decompression, obviously interspinous process devices can be more effective than non-operative therapy in improving quality of life. When you look at interspinous distraction devices like Vertiflex compared to open decompression, some studies show similar outcomes and some studies show worsening outcomes with interspinous distraction devices compared to open decompression. There is a higher risk of reoperation when it comes to interspinous distraction devices. With interspinous stabilizing devices compared to open decompression, there was a study looking at Coflex, and 90-day complication with Coflex was higher, but in the long term, there was no difference between it and open decompression. And this was a study that used the MOD database, and basically what the MOD database is, it's basically manufacturer and user facility device experience data, where patients and providers can go and report certain side effects. And basically what this study did was look at 3 different devices, the Coflex, which again is the interspinous stabilizer, the Vertiflex and X-stop being interspinous device distractors. They use different criteria to determine statistical significance. But basically, if you can see on this image here, you can see that there have been side effects, more particular focus on the Vertiflex because that's the one that most pain physicians will utilize. There's been allergic reaction, so there's been fractures, there's been device migration and worsening pain after placement of the device. This here is a heat map, and basically what a heat map is, it's not comparing complications with each device to the other, but just kind of shows you complications that have been reported that are considered statistically significant. I'm running out of time, but if you look at here at the Coflex, statistical significance is considered an informative component of greater than 0, and that's indicated by the green bars. So you can see that there's statistically significant pain worsening, symptoms, migration, and fractures. With the Vertiflex, there's statistical significance and side effects such as fractures, migration, and again, worsening symptoms. With the X-stop, worsening symptoms, migration, and fractures. So in conclusion, we are seeing more and more patients that have lumbar spinal stenosis as our population ages. We need to determine whether or not we're going to manage conservatively, minimally invasive, or surgically. Yes, interspinous process devices can benefit patients, but it is really important to have an interdisciplinary team, which basically consists of your ortho, spine surgeon or neurosurgeon, as well as your physical therapist, so we can try and determine what device should be utilized in patients, as again, we need to individualize therapy. Sorry for running 2 minutes over, and I will hand this over. Thank you for joining us tonight.
Dalia, excellent presentation. No worries, I really appreciate it. And we are moving forward to the last presentation of our webcast. And it will be presented by Drs. Meroney, Amir, Jafari, and Rohan Sarna from the University of Florida. I think Dr. Meroney is going to take the lead with his presentation or part of the presentation. Matthew, welcome.
Thank you, Dr. Przkora. So mine is, I like to call it the Introduction to Endoscopic Spine Surgery, which is specifically endoscopic rhizotomy. So the idea is it's an endoscopic approach to perform lumbar radiofrequency ablation, same target, but there's some benefits. So I like to state, like, this is a great way to, add value to your clinic, to your practice, to get involved in endoscopic procedures, but also to mitigate concerns from our surgical colleagues of, maybe causing concern that we're kind of, encroaching on their turf too quickly. So this, again, is just an endoscopic approach to perform lumbar radiofrequency ablation. So completely within our realm of, duties. Here's a case report of mine that I think kind of explains, where its value is. So I had a patient that, long story short, had an L5 S1 fusion, so hardware at L5 and S1. Was facetogenic, got MBBs followed by traditional RF, and was very successful on the right, 80% relief, and unsuccessful on the left, only 10% relief. On exam, he still seemed very facetogenic. So I was, even though I felt that the ablation was done as correctly as possible, I was concerned that due to the fact that there was hardware at the levels causing adjacent segment disease, the pedicle screws were likely in the way and impeded my ability to treat that area. So just to reconfirm, I pursued a repeat medial branch block, which is not required, to confirm my, that is what I was obviously chasing, the facetogenic pain. I performed an endoscopic rhizotomy just on that left side, and his pain relief went from 10%, or realistically none, to per him 99% pain relief. Just to kind of give you some basics, this is the equipment. It's not all the equipment you'd pursue using for endoscopic decompression, but you have an endoscope, which is the camera. You have a dilator, which helps you advance the working tubes, which there are multiple. There's a forceps or a pituitary, which is a grasper. And this is one of the main tools called TriggerFlex. It's a radiocautery device that is you can easily manipulate, kind of like a finger. You can, if you engage the handle, it will extend and flex in the direction you point at. So you could practically sign your name with this thing. In addition, there's a Quad Pro, which is 2, so double the horsepower, and then Bi-Tip, which is one that's a little bit cheaper, and there's no, you don't have the ability to engage it, but it has an angle to it, and it's very powerful. So from a basic standpoint, what does the access look like? So kind of as you would expect, your incision points, you can go from, 1 at each location or less, depending on your comfort level. And you're going to land your scope directly where you would ablate. So just lateral to the pedicle, you enter. It's only about, probably a centimeter realistically. I wouldn't even see a 1.5 centimeters. You will, some of the learning points, which obviously is easier with hands-on experience, but you will penetrate the fascia, which can be a little unnerving when you're using a dilator and pushing what feels kind of like a spear to advance through their back. You'll pop through that. And then you'll touch base on the bone, obviously depending on what bone you touch first, but the goal is to land on the transverse process. And I like using a technique called the windshield wiper technique, where you palpate the transverse process with the tip of the dilator, which will confirm that you are in the exact location. You can feel every single piece of anatomy. So you can feel the walk-off on the cephalad and caudad aspect of the transverse process, and then, on the junction to the vertebral body. and that will be the target. And doing that will also kind of debulk and kind of remove some of the tissue and speed up your procedure. So this is a good example of where this procedure shines, because if you can tell the working channel is just adjacent to the pedicle screw. And if you can kind of appreciate that my device is extending anterior and kind of underneath the pedicle screw, which is likely where, you know, the post-surgical changes caused the medial branch to grow, which, you know, made it difficult to access from a traditional radiofrequency ablation technique. So the cool thing about this is you can literally see, you could see the head of the screw. You know, if someone gave you a screwdriver, you could unscrew it, not that you'd want to. So considerations is that this compared to, you know, obviously it's, this will require more anesthesia, so you want to take that into consideration when offering it, but also it could be the reason that a patient may not need a fusion, so you might save them more extensive procedures and anesthesia. Things to think about is, you know, preferably the patient's had, you know, you're very suspicious of facetogenic problems. A great person is someone that's already had an ablation and it worked well, but it didn't work as long as you want. This generally, the pain density relief usually is improved. So my patient, you know, the successful side was 80% relief for traditional RF, and this created 99% pain relief. And so someone that's had a prior, you know, semi-successful RF, it would be a good kind of first candidate. In regards to anticoagulation, you don't have to worry nearly as much as, you know, interlaminar ESIs. So, you know, you could do this on aspirin, but obviously that's kind of a personal preference. But I think it really shines where there's hardware that you can work around, which most people, I don't think, are very successful in doing ablations around that material. Here, you can kind of see, you probably want to look at it later, but the medial branch relative to the pedicle and SAP and transverse process, which looks like in a cadaver. And one of the learning points for this is that there is small blood vessels there, which is kind of a positive because it gives you opportunity to control bleeding and practice techniques that are paramount and important for endoscopic decompression, but you're not in a high-risk environment because if there's bleeding in that area, it's not the end of the world. And here's a view of one of our patients where you can actually see the transverse process, the bony prominence going kind of down and to the right. And you can see that this one's probably exposed more than really, this is, I think, actually a cadaver. So I wouldn't really want to expose that much of the transverse process because that would have ablated too much tissue. But you can kind of see the junction kind of up and left where the medial branch would be touching. So statistically, this is supposed to last, I would say, significantly more than a traditional RF. Generally, I would say at a minimum 12 months, but most people argue that it's usually, you know, 3 to 4 or 5 times as long. But that being said, I don't have a randomized control trial to reference from, but I've had, I would say, pretty good luck with this, or relief. Safety things to touch on is that you don't want to ablate the entire transverse process because it'll denervate other muscles like the iliocostalis, longissimus, spinalis, and other skin lateral to the muscles. And the benefit of this beyond the procedure is you get an introduction to the surgical skills that you'll need if you ever want to get more advanced. So don't want to go too far deep into this, but I think you can kind of distinguish yourself. Even if you're not going to do the more extensive endoscopic decompressions, you're going to be able to offer this really exciting procedure that works better and longer than your kind of bread and butter without encroaching onto neurosurgeons. And you know, so I mean, a lot of patients are pretty impressed by it. Post-op, they're really, I would say, pretty comfortable, especially if you put some local, about a few cc's at each location. A lot of times they'll wake up and be smiling and be shocked that they don't really feel much, and they'll help them get home. Obviously, that will wear off, and they'll be a little uncomfortable at home. But generally, it's been some of my happiest patients. And I know there's 2 more quick presentations, so I'm going to jump off.
Dr. Meroney. All right. So I'll be going over the endoscopic lumbar decompression. And Dr. Meroney went over the most common equipment that we do use for this procedure. I actually have no disclosure for this lecture. So I have a short period of time to go over this topic, but I'm going to try to summarize it and hit the main points. Endoscopic decompression, I'm going to specifically talk about the intralaminar approach. There is the transforaminal approach, which focuses on pathologies in the foramen, where the exiting nerve comes out, and also the intralaminar approach, which focuses on more of a central canal, lateral recess narrowing, and some of the medial portion of the foraminal narrowing as well. When patients ask, what's the difference between open surgery and endoscopic, I try to explain it in a way where it's easier to understand, where I say it's like in a sniper method, where you try to get to the problem area as close as possible without causing much damage in the path. And the incision is extremely small, doesn't require much injuring of the muscle as you're trying to reach the target area. And the goal is to basically remove as little as possible, but remove the most problematic pathology. So some of the things that you want to focus on when you're selecting patients for this procedure: age, of course. You want to look at and see if they're younger patients, they're going to be more active. You're going to look at their lifestyle. This all comes into consideration when you decide what type of procedure to offer these patients. Versus older patients, they're not going to be as active. Some of my patients, they just want to spend some time playing golf and enjoying their day, and that's it. And not that golf is not a very, active sport, but this will allow me to decide how much tissue and bone and structure I can remove through this procedure. Comorbidities, this is a procedure done under general anesthesia, so you have to consider that. Are they going to be able to tolerate general anesthesia? Well, severity of the stenosis. Again, to be able to offer this procedure, you have to be able to understand MRI and be able to interpret it, read it yourself, because the report is not enough. If there's severe stenosis to a point where there's clumping of the nerve roots, that means that there's definitely adhesions in there where things are stuck together, and going in there and try to peel off ligaments, off the dura, there's a high risk of tear and bleeding. Location of the stenosis is very important. Again, like I said, it's like a sniper approach where you're trying to find the target, and knowing your anatomy, understanding MRIs, and trying to decide where to go really affects the surgical approach you take. Even the starting point and the target point where you're going to go. Patient expectations. A lot of these patients that we work with have multiple pain generators, and we try to use our interventional pain procedures, diagnostic tools, to figure out which one is the most severe pain generator and go after it. But I try to explain to the patients that, this is not the only problem you have. So my goal is to take care of the worst one and hopefully in the future go after the next one. Any history of lumbar surgery, you got to figure it out. The first thing I do is look at the patient's back. Sometimes people don't even remember they had surgery before. So I make sure that I catch any old scar tissues in the back. That's happened before where, people say I never had surgery, and then you see a scar. Presence of previous surgery creates scar tissue in the target area. Not that we don't operate on patients who haven't had surgery, but definitely makes it much more complicated, because scar tissue means adhesions. Adhesions means increased risk of dural tear, increased risk of bleeding, because imagine you put a tourniquet around the arm, the vessels get engorged. Same thing happens in the spine, the vessels get bigger. What type of pathologies can you treat with this procedure? Large disc herniations, facet joint cysts, large bulky degenerative facet joints. Again, the spine, as we age and have more birthdays, the facet joints hypertrophy. I say this is the best way for the spine to protect itself by hypertrophying, getting thicker, but then that process, anything in the way gets compressed. And that's where you get the canal stenosis, lateral recess stenosis. Degenerative disc osteophytes, ligamentum flavum hypertrophy, Bertolatti pseudojoint. This is when the transverse process of L5 starts touching the sacral ala and either turns into a full-on joint, fuses, or it's a pseudojoint. Central canal, lateral recess, and foraminal stenosis, and post-surgical scar tissues. These are all targets for this procedure. On the initial evaluation, I have been working with the fellows trying to make sure that we, do a full-on physical exam, including each muscle groups, and also you want to document any reported weakness and document the actual weakness that you see on your physical exam, numbness, symptoms of neurogenic claudication, pain, numbness. Make sure you document the dermatomes, because all this information is used to figure out your target, because a lot of these patients have multiple pain generators. So if you know the dermatome, you match it to the MRI, and you match that to the results of your diagnostic blocks, this story comes together and helps you figure out where to go. Previous interventional pain procedures, again, who it's done by. I try not to rely on other physicians' procedures. I try to do my own. A lot of times, you know, these procedures have been done many years ago, and the anatomy changes. So previous spinal surgeries, need to know the level, type of surgery they have done. When you document physical exam, motor, sensory, reflexes, straight leg raise, don't forget to evaluate the hip and the SI joint, as those also can contribute to the lower trunk pain, lower lumbar pain. And these, for example, SI joint pain can radiate. Any history of bowel or bladder incontinence, you got to figure out, is it true bowel and bladder incontinence? Is it chronic? How many years has it been there for? Are they seeing a urologist? These information will be used for later on if you find out that the patient had incontinence after surgery, and you look at the note and you realize this could possibly be a chronic issue. Imaging evaluation, it is extremely important and hard to learn, because it's difficult to get trained in reviewing MRIs in one-year fellowship. Flexion extension X-rays, tells you a part of the story of how much there's instability, but not the whole story. End plate edema on MRI, spondylolisthesis, swelling of nerve roots. Again, swelling means there's severe compression. Facet joint widening, facet joint fusion, and lumbar CT. On lumbar CT, a lot of times you can see that the ligamentum flavum has not only hypertrophy, but it's calcified. So it's much harder to take off and decompress. So I think I only have about 5 more minutes left, so I'm going to quickly go over one of my cases. This is a male in his 20s, history of lumbar radicular pain for 1.5 years. Pain is purely in the S1 dermatome, posterior thigh, posterior leg, and he had positive straight leg raise on the right, and weakness in the EHL on the right. Patient was evaluated by our neurosurgeon, who offered the patient either tubular discectomy or endoscopic decompression by us. And I evaluated the patient and offered him the endoscopic decompression. Offered patient minimally invasive injections and things like that, but he did not want to proceed with those. And because he had weakness, we decided to proceed with the endoscopic decompression. So here is his disc herniation. I'm gonna go ahead and scan down, since I don't have the whole MRI image up. I'm just gonna scan down the lumbar spine as each image. And as you can see, that there is a massive L5-S1 disc herniation on the right, completely compressing the S1 nerve, the traversing nerve, and pushing the whole dura to the side. And there's definitely edema there. And I'm scanning down one more. Actually, this was the middle, this is the top. Definitely extruded. Anyway, this is the flexion extension X-ray. You don't see much spondylolisthesis, everything is aligned. With regards to evaluating for instability, we don't just rely on the flexion extension. There are multiple other factors we look at. I usually like to also now look at the standing scoli X-ray and compare that to the actual MRI and see how much different there is. And look at the facet joint size, if there's any fusion in the facet joints at that level, and is there hypertrophy of the facet joints, end plate edema. These all indicate that there's stress in that joint, and the structure that's there is supporting the spine, and removing that structure can worsen your instability. All right, so the question is, I get a patient like this, when do I order an updated MRI, or how old of an MRI can I rely on? Good question. I mean, This picture right here on the left was 8 months before the procedure. And this picture on the right was 1 month before the procedure. As you can see, this disc has migrated downward, which makes my job much more difficult, right? If I know that it has migrated downward, then I will change my entry point and also the drilling position. Obviously, this is a very large disc, and even though it's L5S1 and there's a large interlaminar window, there's got to be some drilling done to be able to get access right to the side of this disc, to be able to, look medial and be able to go medial enough to capture all this through the disc. Because if I just focus on this area, I'm going to leave a big portion of disc in there. And yeah, the patient may get relief for 6 months, but it will be back again with radicular symptoms and inflammation down there, and probably end up getting a big laminectomy. So our goal is to be able to take off as much as possible whatever is the pathology, so these patients don't have to come back for another surgery for many years down the line. And looking at the size of the incision, I most likely barely caused any trauma to the muscles as I entered my scope, as I advanced my scope. So this is the new MRI, and it definitely shows worsening of the herniation. So now, if it is a young patient and a clear herniation, I'd like to have an updated MRI within the past 3 months. If it's an older patient, that pathology is not disc herniation, it's more like ligamentum hypertrophy, facet joint whitening, and osteophytes, I like to have an MRI within a year. Most likely this pathology doesn't change within a year unless their pain has worsened, much worsened, or new neurologic symptoms have developed, then I will order a new MRI. Again, this is the difference between 8 months and 1 month. As you can see that it definitely looks worse. The S1 nerve is completely compressed, and the patient could barely walk. So he was very eager to proceed with some sort of decompression as soon as possible. This is the working tube that's placed. Obviously, this wasn't just in the beginning of the case. There's definitely drilling, and this is the trigger flex device, as I have advanced the working tube down by using the drill and trigger flex, slowly decompressed lateral to the disc herniation. This is where I have reached the anterior portion of the SAP and try to take off some of that SAP. So in the future, if this patient develops any lateral herniation, then, hopefully it will be asymptomatic. And this bone you see right here is most likely the other side, the contralateral side. And the trigger flex, the tip of it actually is used to sear off any annulotomy that we've created, and also any previous hole that was there that actually the disc extruded out of. So then in that scenario, searing it off and basically burning it will harden that disc and prevent any future reherniation. This is an image of me grabbing the disc with the pituitary device and pulling it out. And this is the big portion of that disc coming out, disc fragment. And this is this is the discs we were able to collect and put it on table. There was definitely some lost throughout the process, with the irrigation fluid and everything also. However, this is a good image of what we can get out. Now, this is not from this patient, but I think this is a great image where you can see the dura. This is the traversing nerve, the lateral portion of it. Underneath it, the decompression has been completed, so you see a shadow. That's a good indication that there's decompression. Also, how do you know when enough is enough? You decompress. When do you think, okay, when do I stop? Well, our goal is to decompress all the way down from the cauda pedicle all the way up to the base of the spinous process, and be able to see the exiting nerve and also be able to see the shadow. And the most important thing is that when you stop and look at the dura, you will see the dura be pulsatile with every breath and every heartbeat, and the dura will move back and forth. And that will show that there is, at least in this segment, there's not much compression pushing on the dura and making it tight. And then also to evaluate for any bleeding, we will stop the irrigation and we'll take our time and look around and make sure that there's no pulsatile bleeding or even oozing. Obviously, if we see bleeding, we'll try to cauterize it. And if there's a lot of oozing, then, you know, at some point, we will just inject flow seal and that helps stop the bleeding. I'm going to go ahead and hand it off.
All right. Hello, everybody. My name is Rohan, Sarna. Dr. Meroney and Dr. Jafari set that up beautifully. I'm just going to share my slides here. Give me a second. Well, thank you for joining us this evening. I'm going to spend my time doing a case discussion. I think that's the best way we can tackle this really complex topic. I hope everyone can see both my screen and me. Give me 1 second. Okay. So I have no disclosures at all. So we'll start off with this case presentation. It's a 37-year-old female who was weightlifting back in August of last year, and she developed acute lower back pain with specifically left lower extremity weakness and numbness. Interestingly, she also had this left knee swelling that came about 2 days after the episode of weightlifting. She sought evaluation, was referred to a pain doctor at an outside facility, had physical therapy and a transforaminal, which resulted in some minor improvement in her back pain, but no difference in her numbness and weakness. So at this point, her PCP sends her to an outside neurosurgeon. So this is her MRI, again, preoperatively in August, and I will do 3 MRIs. I'll show you this cut, I'll show you one without the yellow lines, and I'll show you one with a big arrow in case you miss what I'm talking about. So we can see on the left side, there's an extraforaminal far lateral disc that's contacting her her exiting L4 nerve root, which explains her legs, her numbness and weakness. It also explains her leg swelling. And you can see that clearly right there. You can even see on the sagittal cut, there's edema in that L4 nerve root. So she then goes for microdiscectomy with a neurosurgeon in September. As soon as she woke up, her numbness and weakness completely improved in the PACU, but she had significant burning and dysesthetic pain in that same distribution as soon as she woke up. So she kept telling us, she kept telling them something is wrong, and they tried some conservative therapy thinking it was just some post-surgical pain, but she continued to have pain from September to October, so they repeated an MRI. Again, these are the slices that I'm looking at, both axial and sagittal with the T2 image. Look at the size of that DRG on the left side. It is incredibly huge and explains specifically why she was having this aesthetic pain. Compare that left side to that right side. It's almost like double the size. Again, by doing these procedures, we see the importance of looking at your own images because there's so much we can learn from this, right? I can't move my cursor around, but if you look posteriorly to that blue arrow, you can see that's their surgical tract. She did lose some muscle bulk. And if we compare this muscle, which looks like there's some atrophy starting to set in, compared to her pre-op, you can see that's really nice, dense muscle at the exact same level with no surgical bed. Fortunately, she continued to be active as much as she could. And we'll look at her muscles again, as well as her MRI in upcoming MRI. So she then came to our facility, looked for a neurosurgeon for a second opinion. And before coming to see us, she had an MRI. I'll show you the MRI in just a second. She was then discussed at our multidisciplinary case conference, which includes pain doctors and spine neurosurgeons. And the neurosurgeon said, why don't you send her over for a TFESI? This was her exam at the neurosurgeon initial visit. So you can see she's weak in her L5 and S1 distribution. That's actually sort of referred pain from the left side, from that L4 being really, really caught. And she also had diminished ankle reflexes. Now, this is the MRI in November prior to coming to see the neurosurgeon. So you can see the size of that left DRG has shrunk somewhat, but you're starting to see there's that annular ridge that's intact, but there's some like either nucleus pulposus or post-surgical necrotic debris that's still within that annular annulus, and it's bulging out toward the L4, which really explains why she continues to have symptoms. So that's again what I'm looking at right there, where the arrow's pointing is the high intensity zone or annular tear with the annulus intact. So she came to get an a transfemoral injection with our clinic. And this picture again shows you the importance of looking at your own images, because we can see I don't need a lateral image for this. I can really nicely see that the traversing nerve roots are outlined with this epidurogram. So it's a really, really nice picture. So I'm very comfortable with this injection. And so was she. She was like, I got 100% of relief for 4 hours. I was so happy. What do we do next? So she came back to see us in February. She had worsening pain. Again, looking at that same spot as before, look at that area of white. That area of white has increased in size, which explains her worsening pain. I'm going to point to it again. And this is the area where she's having either nucleus pulposus leaking out to there or post-surgical necrotic debris. But the other thing that's really nice is look at that behind the DRG, her muscles are back to normal. So that's the nice thing about endoscopic and microscopic procedures. Your muscles heal really quickly. With endoscopic stuff, and I'll show you in a second, we actually spread the muscles away using our dilator device, which is sort of, there's a tip to it, and therefore we're actually muscle sparing, which is really, really nice, and which is what everybody wants. Unfortunately, she hasn't undergone surgery yet, so we already scheduled her for a left L4-5 endoscopic decompression, but as opposed to Dr. Jafari, when he was talking about coming in from up top, we're coming in from the side. Now, I'm going to show you a different patient with the exact same pathology of the right L3, and you can see right there where the arrows, where the lines are, he has a far lateral disc contact with dysesthesia symptoms in his right L3 distribution. Again, I'm going to just point to it. So I'm going to show you his intraoperative imaging now. So the whole basis behind this theory is we can dock our working channel and the dilator at the Cambin's triangle, because we know that the traversing nerve root is going to be above us. So if we dock anywhere between that pedicle to that superior articulating process, we are going to be safe. So now remember, as you're at L2 and above, you still have kidney in the way. So you got to be careful and look at your preoperative MRI to make sure that your trajectory does not spear through the kidney, because you can get severe bradycardia at that point. And of course, the lower down you go to, the more lateral of an angle you have to take to get to that junction between the pedicle and the superior articulating process. And the other thing you notice here is they don't really show a line for L5 a lot of the times, because the L5 exiting nerve roots, sometimes you get the crest in the way. And so for that, it might be easier if it's not a far lateral disc to do an interlaminar approach, because the interlaminar window is much, much bigger. So this is how we do it. And caution here is your needle cannot be bent. So for a lot of pain injections, sometimes you can get away with sort of bending the needle or twisting and getting it to your endpoint. For this, remember, the needle's only the starting point. You have to put a guide wire through as well as a dilator through. So if your needle starting trajectory has a little bit of a bend to it because it's going through muscle and fascia and soft tissue, that's going to make your end docking with your working channel and your dilator really, really challenging. So it has to be nice and straight. We're seeing the AP view here and the lateral. We're actually going to correct this to make it a little bit more anterior and a little bit higher on the superior articulating process. And the next thing that goes through this 16 gauge needle is your guide wire. And your guide wire looks like this. And we didn't save the images, but the guide wire goes in, you touch us, you make sure you're on us, you pull the needle back somewhat, you make an incision above and below the needle, and then you advance your dilator. And you can see the dilator has a tapered edge to it, which again spreads muscles and doesn't cut muscles. And compared this image to this image, we can see we docked higher up on that SAP, you could even dock more anterior. And what you'll see is this guy. So this is our endoscope put in through our working channel. The working channel goes over the dilator. This is endoscope on the right, and the working channel with the dilator still in on the left. And you can see we have a beveled working channel, and that allows us to protect the nerve root or open toward the nerve root. That gives us more space to work on. There is a flat working channel, which may be better for endoscopic rhizotomies. But the reason we choose this here is we can sort of protect the nerve and work away from the nerve, or open up to the nerve and look directly at it. So again, this is the Cambin's triangle. We have this beveled working channel. And now if you look on the left of the screen, we're actually opening up to look at the exiting nerve root. Now, a little disclaimer, this far lateral technique Endoscopic is really, really good for it, but it's a little bit more of an advanced procedure because your hand is hanging out in no man's land. For a disc that's herniated centrally or paracentrally, you actually put your endoscope and working channel through the foramen, and you can actually let your hand go and it's not going to move anywhere. But I wanted to show you this case because there's a lot we can see MRI wise, and this is really nice because far lateral disc endoscope is the perfect tool for it. And I wanted to show you this. This is the trigger flex instrument both Dr. Jafari and Dr. Meroney mentioned. You can go pretty high and pretty low just by that one move. And you can actually see on the left image, your working channel is pinning or looking directly at the exiting between the pedicle above and your endoscope below. So you can actually see the exiting nerve root. And like Dr. Jafari said, you want to make sure that it's pulsatile when you're done with your case. This is an image from a cadaver and a lab, and you can see you can actually drill through hypertrophied superior articulating processes, and that's your visual. Now I'm going to give you sort of a black and white view of what that looks like when you get to the dura. And remember, you're not taking a top-down view, you're doing a side view, and so you can actually see herniated disc right at the bottom. You can see dura right at the top. Sometimes you can even see ligamentum flavum overlying the dura. You can see posterior longitudinal ligament, and then you have to get your orientation of what's cranial and what's caudad. It's hard to say that with pictures, but when you're doing the procedure, you're looking at the patient and you're looking at the X-ray, and so when you make little movements, you can actually tell what's cranial and caudad. This is a really nice view of what we're looking at. So the top left view A is you drilling through that pedicle and superior articulating process. B, you can see ligamentum flavum getting in the way. So they're using a Kersen-Ranger instrument to move that away. TNR is traversing nerve root. If you go cephalad, and again, toward if you just follow it cephalad, you can actually see the exiting nerve root. And then you can see disc, or you can see a far lateral disc. So this is a very, very good technique because you can see everything with your own eyes. And I wanted to show you, you can do an entire facetectomy from this lateral approach. You can even come in at a flat trajectory and get anterior to the dura and take out midline or even contralateral disc herniation. So this is a technique that's very, very interesting, very, very helpful, and it's a true decompression technique. So this is definitive treatment. I'll leave my email up here if you want to ask any questions, but I think I am done with my section. Sorry for running a little over.
No problem. For the endoscopic team also, thank you very much for your presentation. I think we have a few questions which we unfortunately cannot attend, but I think the excellent presentation and this important topic for us pain physician was worthwhile doing it. And we will answer some questions, in writing. We'll be happy to do it. And again, thank you very much for joining us tonight. And I would like to use the finishing sentences, on behalf of Azra Pain Medicine and the APPD. I would like to thank you for the participation in today's events, the audience and the speakers. The next Azra Pain Medicine APPD Hot Topic webinar will take place on May 7, again, Tuesday, May 7, 7 p.m. Eastern Standard Time. And we will focus on basivertebral nerve ablation and intrathecal drug delivery. We hope to see you then, and thank you very much and have a pleasant evening.